Right. Well, why don't we get started? Good morning, everybody. Thank you very much for joining us today. This is session 4A, Engaging in Substance Use Healthcare During Pregnancy. If rapport is a two-way street, can clinicians and patients meet in the middle of the road without getting run over? My name is Sarah Clark. I'm moderating this session today. Before I introduce our speakers and we start the session, I'll just give you a couple of reminders. So the session is being recorded. If you have a question during the session, please enter it into the Q&A box, which should be at the bottom of your Zoom menu, and I'll deliver it. I'll be delivering it once the presentation is over. We move into the Q&A session. You can add your comments in the chat, but if you have a question that you want answered, please put it in the Q&A box. Once the presentation is over, you can also raise your hand if you'd like to ask the speakers a question directly. So I'll be introducing now our speakers for the session. So we're still hoping that one of our speakers is going to join us. So the speaker that we have and you see is Dr. Adam Newman, who practiced full scope family medicine in Sioux Lookout and Kingston for 20 years before obtaining certification from the Canadian Society of Addiction Medicine in 2013. Since then, his practice has been focused on addiction medicine and harm reduction exclusively, including perinatal addictions and substance use. He is the most responsible physician for opioid-dependent mothers and infants, rooming in at Kingston Health Sciences Centre, KHSC, where he is also a member of the Substance Treatment and Rehabilitation Team, or START, which provides addiction medicine consultation and treatment for inpatients at KHSC. And we are still hoping that Charlotte Munro will be joining us. Charlotte Munro is, she's based in Stratford, Ontario, and she's a dedicated advocate for equitable healthcare and support services. Drawing on her extensive lived and professional experiences, Charlotte has been actively involved in patient engagement for several years. She has co-authored opioid-related research publications, advised on drug policy, and contributed her expertise to various mental health and substance use advisory boards, committees, and lived experience groups. Charlotte's work is driven by a commitment to addressing social inequalities and promoting trauma-informed harm reduction approaches. She is currently pursuing a bachelor's degree in Indigenous social work and holds a diploma in child and youth work. In addition, Charlotte is a group facilitator with Pay What You Can Peer Support, a nonprofit organization providing accessible, low-barrier peer support for mental health and addiction challenges. And with that, I will turn it over to our speakers.
Hi, thanks, Sarah. And thanks to Jennifer Wyman for inviting me to present, to be part of this presentation. So as Sarah has mentioned, we're still hopeful that Charlotte will be able to join us, and I just wanted to set the stage and explain how we had imagined this session going. So first of all, just out of a stab at a public display of humility, I wanted to just say that when Jennifer contacted me a few months ago and asked if I would give a presentation about engaging pregnant patients in care for substance use, my immediate reaction was, well, I don't know how to do that. It's just the job that I do. It's not something I've ever set out to do deliberately. It's not something I have any academic interest or experience in. But of course, having been asked to do it, I immediately began paying attention to what was happening during my subsequent encounters that related to engagement. And I suggested when Jennifer and I had a chance to talk at the CSAM conference subsequently, she suggested that perhaps that there was also a patient advocate who would be participating, and I thought, well, how about if we try to do a demo and just have as close to a real encounter as possible between a physician and a woman with lived experience, and see how that goes, and see whether, because again, as I said, I don't pretend to be an expert on establishing rapport, except that it's, in a sense, like all of us, it's what I've been doing for 30 years. And to some extent, I'm successful because I have some patients who continue to see me, but to some extent, I'm not. And like everybody else, there are patients who are disillusioned and who leave and don't come back. But being prompted by this to do a bit of reading, I'd actually found it quite constructive and interesting, and I'm quite looking forward to interacting with Charlotte in front of you all. And in order to keep this as real as possible, Charlotte and I only met once, I think, remotely to discuss the concept, and then we've communicated by email. So as much as possible, we haven't established a therapeutic relationship or any kind of relationship before this. Which is to say, I don't have a contact number for Charlotte right now, so I can't get in touch with her. But anyway, well, we will remain hopeful, as I say. So what I was going to propose to do anyway was talk a little bit at first about the reading that I did about establishing rapport, what rapport means, how rapport relates to therapeutic alliance, and so on. So let me just set up the screen share so I can show you my slides. And I want to do slideshow. Okay. So Sarah, can you just confirm for me that
Yeah, perfect.
great. Okay. All right. So and the long kind of jokey title was my invention. Really mainly because it occurred to me that this was not something just for a physician to speak about as an expert. It's something that either occurs or doesn't occur because of the interaction between two human beings. And like any other interaction between human beings, there's all kinds of opportunities for pitfalls and misunderstandings and wrong footing. Anyhow, I have nothing to disclose other than, as I said, I don't mean to pose as an expert. I'm just somebody who's got many years of clinical experience and was willing to expose himself to public scrutiny in this forum while I tried to establish rapport with somebody who was, to her own extent, going to be participating in that process. So to start off with, I wanted to talk about what we mean by therapeutic rapport, why it's important, and then we would go ahead with the demonstration. I've told Sarah that I will just keep on talking until Charlotte arrives, and then we will leave time for discussion afterward. So in reading about this, I inevitably fell upon or was reminded of the therapist Carl Rogers, an American psychotherapist who wrote in the 50s and 60s extensively about the process, about the relationship between a psychotherapist and a client or patient, and thought a lot about how it is that this relationship is so significant and meaningful for people trying to undergo therapeutic psychological change. So he's the guy who's associated with the idea of person-centered therapy. There's lots of YouTube videos of him interviewing people, and he's a very well-regarded sort of important psychotherapist. But what he did was identify these three essential attitudinal patterns that a therapist had to have or display. And first of all, many of you will have heard this before. This is very common now. This has been accepted sort of into just the dogma of behavioral science and psychotherapy. So a therapist had to demonstrate congruence. In other words, had to be authentic, had to appear to be really engaged as a fellow human being in a person-to-person encounter with somebody. They had to be able to demonstrate unconditional positive regard, which is a difficult thing to talk about scientifically. I mean, in reality, some people lately, and I've taken many courses on various types of psychotherapy and am currently, and some people have rightly pointed out, well, unconditional positive regard, that's kind of a euphemism for love, isn't it? You have to, and how do you just acquire love or show love for people that you've never met before? Anyway, it's an interesting topic in and of itself. I won't say any more about it, but the ability to demonstrate unconditional positive regard was important. And then empathy. One had to be able to imagine how another human being was thinking of and feeling in a situation without blurring the line. So losing the as if quality, I think there he's talking about the difference between sympathy and empathy, that you never lose yourself and become engaged as if the struggle, the emotions that the patient is exhibiting are yours. But then we often talk about that when people are talking about their relationship, but there was a fourth condition that he pointed out. And essentially what this says is it's not enough for the therapist to be empathic, to be congruent and authentic, to have unconditional positive regard for one's patients. They had to be able to demonstrate that, and the client had to feel it, had to feel that those things were true and were present. And that's really where the two-way street comes in. This is something that it doesn't matter how much the therapist feels he or herself they possess these qualities. It doesn't matter at all if they're not able to convey this to the client. And then looking at the literature, I found a lot of very interesting stuff written about this. And I'm just going to go through it chronologically, and I just want you to pay attention to the titles of these papers as I go through them. So back in the 70s, this was written by two medical anthropologists who were working at the Lexington Farm in Kentucky, which was a notorious involuntary treatment center, you might say, for people convicted of drug crimes in the United States. And William Burroughs, among other many famous people, spent time at the Lexington Farm. And in its own way, for what it was, I suppose, some of the writing that came out of there was what you might call enlightened, although it really was a prison. So what they talked about was this sociocultural barrier to establishing therapy. So there you see, establishing therapeutic rapport, this term, which actually kind of blurs. So what Carl Rogers was saying is that you have to be able to establish rapport in order to have a therapeutic alliance, a therapeutic relationship. So here they've kind of blurred, and they're talking about therapeutic rapport, meaning the same thing. You're trying to engage with somebody so that you can have a positive outcome. And you see that they talk about this is a problem in the treatment of narcotic addicts. So this is very objective, is objectifying. It is rather disempowering, talking about these addicts, people who are identified by their addiction and who need to have something done to them. They need to be treated. And really the most interesting thing about this is that this paper did acknowledge that there was this relationship was really hindered by stereotyping on both sides, that it wasn't just addicts or it wasn't just addicts who had negative stereotypes about authority figures and shrinks and psychiatrists and staff working at the farm. It was the staff themselves, the physicians and psychotherapists, who had negative attitudes, preconceived attitudes about the people that they were supposed to be engaging with, and that this was a barrier. And it explored ways of trying to break down and get over this barrier. The next paper I looked at is about 30 years later, and this is by a non-MD therapist, George Joe, who wrote extensively about this. What they actually did was try to quantify what the relationship was between successfully establishing rapport and a positive therapeutic outcome. So very interestingly, they were able to say, so they said, okay, so in this sense, we're talking about rapport is the extent to which the patient and the counselor are on the same wavelength and are caring for each other's well-being. So there's a mutual understanding and a mutual concern that has to happen. And they measured it. So they gave questionnaires to both therapists and patients over the course of a treatment course that was preconceived. This is a randomized controlled trial. And what they did was they questioned at the end of this therapeutic process, they questioned each of the participants, the therapist and the patient. So some of the questions were the same. Was this other person easy to talk to? Were they warm? Did they appear warm and caring? Were they honest and sincere? did they demonstrate understanding? And in the case of the patients, they asked about your therapist, did you find him or her suspicious, hostile, or aggressive, interestingly? On the part of the client, about the client, they asked the therapist, is your client, is your patient still in denial about the problem? Are they avoiding taking responsibility? And these things together, they modeled them and put together a score, and they used this score to quantify how good the rapport was between each of these couples. And then they looked at the outcomes, and they were able to show a significant relationship between greater rapport and decreased cocaine use, decreased heroin use, decreased criminal activity, and longer retention in treatment on the part of the patients or clients. So again, interestingly, and this really just occurs to me, so I'm not entirely sure that there is any literature to date which contradicts this. So there's nothing about how the therapist does and how the therapist feels. Anyway, this is really all about enacting a change in the client. So then jumping up several years to the 2010s, this is an article, head author is Henry, I don't know how to pronounce Henry Jones' first name, but she's very well known in writing about substance use in pregnancy. And I thought this was a useful and worthwhile paper because it actually talked about some of the practical things that one had to do. And they just determined this by just talking. It was a review article. They reviewed and talked to patients about how they felt about their clinician's ability to establish rapport. So establishing and maintaining eye contact, allowing the patient to speak without interruption, using nonverbal cues, and using the patient's own words to summarize, in a sense, being able to demonstrate that you really have been listening. And anybody who's familiar with motivational interviewing will recognize a lot of this. This is essentially, these are the things that one has to keep in mind or be able to do in order to facilitate motivational interviewing. And so they just concluded that the data that they reviewed showed that there is evidence that if you can project a caring and non-judgmental attitude, you can engender trust and facilitate communication, and patient-provider rapport increase the likelihood that the patient will disclose an accurate history of licit and illicit substance use. So again, this is in order to extract something from the patient. If you can get them to feel that you are sincere and engaged in a real relationship, you can get more out of them that is important. But always keeping in mind that you have to actually sincerely engage in a relationship. So then once you've extracted information from somebody for whom you actually do care, you're not going to be neutral and completely objective with what you do with it. And then they summed up in the discussion a couple of things that I have found to be particularly true in the care for people who are pregnant and are struggling with substance use. So that opioid use on its own doesn't require a referral to a maternal fetal medicine specialist. And this is funny, ironically, because much of my work currently occurs in the maternal fetal medicine clinic at a tertiary care academic teaching hospital, where women are often referred just because they have a substance use disorder or a history of addiction or substance use has come up. But then further, that referring to an addiction medicine specialist isn't a handoff of care, that it should be integrated into obstetrical care, that seems to be a quality of the most successful programs and models. And having said that, just to self-reflect a little bit, up until this past year, up until December of 2024, I posed as somebody who took on that role, in a sense, taking over the care of the patient. So I was a family physician who did low risk obstetrics. So I was able to take over antenatal and intrapartum care of women who didn't have any medical. So if the only reason for referral from a family physician or a midwife was because of their substance use, I did not feel the need to refer them on to obstetrics. I would continue to follow them and provide primary care. And because I was a physician who was able to prescribe methadone and later Suboxone and other forms of buprenorphine, I would be both their addiction physician and their obstetrics provider, which I thought was very enlightened and wonderful and great. But thinking about this now, it actually it explains to me a little bit about why I have stopped that role without causing any deficit in the community to my knowledge. Um, and it seems to work very well that I act as somebody who's brought in by the obstetricians caring for the patient to follow them along through the pregnancy. And yeah, so that's my impression, and it's not something that I've ever set out to actually measure or quantify among the people whose care I've been involved in. So having said that, and that it is really just following on the model. So the maternal fetal medicine clinic at Kingston Health Sciences Center also has a obstetrics and endocrinology clinic where there's an endocrinologist who's present, as well as the obstetricians. Oh, and I think I see that Charlotte has appeared.
Welcome, Charlotte. Thank you very much for joining us.
So
Hi.
so let me I'll just close now, and I just what I did want to point out, this was just if you think, I remember I mentioned the titles of those articles. So we started off in 1974 talking about treating narcotic addicts. That's very objective. That's not person-centered or patient-centered language. The 2001 article was more balanced and open, but still talked about drug abuse, which is a very judgmental way, that a term that we try not to use anymore. We talk about substance use, and we even avoid the term substance use disorder necessarily. We talk about substance use health. And then finally in 2014, that article by Jones referred to opioid using pregnant and postpartum women. So they put the patient first, I mean last here, but it was the noun being modified was that they were women or people, and that they happened to also be pregnant and using opioids. So it was just, I thought in the context of establishing rapport, this kind of says a lot about how our attitudes mutually, both on the part of the patients, the people that we meet as patients, and the way we behave as physicians or counselors, is governed by the environment around us. So there we go. So I'm done. I do have references, and I will stop sharing now. Great. Oh, so I guess, okay. So hi, Charlotte. Um, I there we go. Sorry, just getting rid of my screen. So we what I said at the beginning before you showed up was just that you and I both have experience in the field of pregnancy and substance use and medical care, and we both were agreeing to pretend to be having a clinical encounter. But just to be clear, this is not a clinical encounter. I'm not interviewing you as a patient. You're I think you're playing yourself in this role, just as I'm playing myself. But you're going to be talking about a composite, a bunch of stuff that you've put together from your own experience. This is not a clinical encounter about your own personal medical care right now. Correct?
Okay.
Okay.
Yeah.
Thank you. And so we'll just jump right in. So Charlotte, Dr. Wyman referred you because she told me that you found out you're pregnant, and I understand that you're happy about that and looking forward to having this baby. Is that right?
Yeah. Yeah.
Great. Congratulations. But she said that there had been issues in the past, that you had a pregnancy previously where, because there was a history that you had a history of having used drugs, you felt that your care was kind of compromised or didn't go very well. And you were
Yeah.
concerned about being able to talk about that and anticipate that and hopefully avoid some of that this time. Have I got that right?
Yeah. Yeah. I had issues going to any prenatal appointments because of just like feelings of being stigmatized and the treatment that I received. So I want to be able to get prenatal care and not have those barriers.
Right. So listen, I want to ask, I'm going to ask you a bunch of questions about your pregnancy and about your past health. And just to remind you about your right to privacy, everything you tell me is confidential and is protected by law. I can't reveal it to anybody else who isn't part of your care team. So the nurses and other physicians here, of course.
Mhm.
I will write a letter to Dr. Wyman telling her what you and I discussed. But there are three specific conditions under which I have to break your confidentiality and report you. So if you
Mhm.
tell me that you're planning to harm yourself, if you tell me that you're planning to harm somebody else, or you
Mhm.
tell me about a child who's being neglected or abused, I have to
Mhm.
report those things. But I just want to be clear, and I always say this to people that I'm meeting in this context, substance use in pregnancy is not child abuse. Just so that we're clear, that is not something that I would report to Child and Family Services in and of itself. So I just want you to hear that from me and know that's the case, because I'm going to ask you about a bunch of intimate and private things that may have happened in the past, might be happening now. And if you're uncertain about whether what you tell me is going to lead to a report, feel free to ask me.
Okay.
Okay. So,
Mhm.
so tell me, do you know about how far along you are?
Um, I would say maybe 6 weeks.
So I'm guessing you haven't had an ultrasound yet.
No.
Okay. And can I ask, I started off kind of putting words in your mouth. I said, oh, I guess you're pregnant and you're happy to be pregnant. But is your concern about the possibility of you being made to feel bad about your substance use in the past, is that something that's going to influence whether or not you decide to stay pregnant?
It had some influence on a previous pregnancy that I had a medical abortion on. So, but I kind of I wanted to maybe like still decide about how I was gonna go about this one.
Okay, so you're still open-minded. You're still
Hmm.
figuring things out. Great. Um, so you think you might be about 6 months? Sorry, 6 weeks. That's a
Yeah.
big step. Um, and can I just ask, do you have a current, I know you see Dr. Wyman at, I, actually tell me, what clinic did you meet her at?
So she was my physician like when I was doing uh OAT, so that's how we know each
Right,
other.
okay, because she worked at a methadone or an OAT clinic,
Yeah.
right? And can I ask, are you still currently taking OAT?
No.
All right. And do you mind telling me what prescription medications are you on right now, if any?
I'm not on any.
Okay. Do you have any drug allergies? Any allergies to anything?
No.
Okay. Um, and if you don't mind, tell me a little bit about that pregnancy that influenced you later, the pregnancy that didn't go well. Can you tell me? I presume you had a baby, right?
I
And
had one baby, yeah.
that's a little boy.
Yeah.
And how old is he now?
He's 3.
3. And do you mind telling me his first name so I don't just have to keep referring to him as him?
Malcolm
Malcolm. Okay. And where are you and Malcolm living currently?
in Stratford.
And do you guys live alone?
Yes.
And you have full custody of him?
Yes.
And was child I don't in my neighborhood where I live, we call it Children's Aid or FAXFLA, which is a long acronym, but what do you call it in Stratford?
CAS.
Yes. Okay. Was CS ever involved? Did anybody call
Yeah.
CS and involve them?
Yeah. Before he was released from the hospital, I had a worker meet with me, I guess.
Okay. But they didn't need to follow you once you got home.
No.
So tell me a little bit about that. How did it come to be that a CAS worker was called to come see you in the hospital?
Well, from what I had learned, I was visiting from in the evening because he was in the hospital for a little while. I was visiting in the evening, and one of the nurses on the shift or whatever reported that I smelled like marijuana when I came in. So
Ah,
that was what initiated the call.
And when you say you were visiting, do you mean was he in the NICU or the NICU?
Yeah, or
Okay,
it's a special care nursery.
so you came into the special care nursery just to be with him, and a nurse thought that you smelled of
Yeah,
cannabis or weed. Okay.
yeah.
And were you on OAT at that time?
No.
So can I ask why was Malcolm in the special care nursery?
So he was born at 7 months, and
Okay.
so he just needed to finish growing. But I had an infection that was like I was septic when they decided to do an emergency C-section.
Oh,
Hmm.
yeah. And so they did a C-section because you developed this infection and they thought he had to be delivered quickly.
Yeah.
Wow. And can I ask, was your pregnancy with him the first pregnancy you've ever had?
It was the second, but the first one was like I miscarried early. So
Okay. Do you remember? Do you mind if I just need to ask you the years that went by. So what year would that have been the first time you got pregnant and you miscarried?
2021.
2021. And then Malcolm, you said he's 3, so was he born in 2022?
Yeah.
Okay. And that was by cesarean section, like an
Yeah.
urgent cesarean section. Okay. And then you mentioned a medical abortion after that. What year was that?
2024.
Okay. So this is the fourth time you're pregnant in total, regardless
Yeah.
of the outcome. Okay. And tell me about the infection and about coming into the hospital. How was that explained to you? Why did the infection happen?
So I presented in the hospital at Emerge at 5 months pregnant with abnormal bleeding, and they did an ultrasound, and it got sent to my doctor, who I did see the following week. I was like really ill, and she didn't identify it as anything, just thought it was just like some, quick virus that I like stomach virus. And then so it wasn't treated, and then it got worse, and then I was recognizing signs of feeling septic because I had endocarditis in 2014 and I was septic then. So I felt like these are similar feelings. I had an appointment with an OBGYN that morning that Malcolm was born. And she told me, I was telling her what my symptoms were and how I felt. And she told me to go to the Emerge. So I did. I presented at the antenatal unit there, and then they monitored for a couple hours and then decided they were going to take him out. So, but I feel like because I presented at that time, like I didn't have an appointment to like talk to anybody about, a birthing plan or anything. Like it was that early. So and like they pulled up my chart in the hospital, and I had that same hospital is where I had the endocarditis based on, drug use 9 years earlier.
Okay.
So I felt like I was treated like an addict still when I was in there. And there was some like, remarks about finding veins and stuff like that, and like, what they were allowed to give me and what they weren't going to give me. So
Right. But it sounds like a real kind of shocking and sudden experience. Like you
yeah,
just go for an OB appointment and suddenly you're at the hospital and they're planning to do a cesarean.
yeah, it was.
And it was like a full like 2 months before his due date.
Yeah,
Wow. That must have been shocking.
it was. Yeah, it was traumatic.
Yeah.
Get it?
Yeah. And can you tell me at that point, how long had it sounds like it's a long time ago that you were on OAT.
Yeah.
Do you mind telling me what year you might have started? I mean, if you don't remember the exact year, that's fine. Like round it off. Like, do you remember what
Yeah.
year you started on OAT?
2013, maybe. I was only on it for about 8 months
And
or
that
maybe a year.
I'm guessing it would have been methadone, eh? That was
Yeah.
before Suboxone was used a lot.
Yeah.
Okay. So you were only on it for how long?
So I had endocarditis in 2014, and I finished methadone in 2015. So it was
Okay.
about a year,
And do you remember what was the highest dose you were ever at?
maybe like 120, but I was mostly around 80. And well, no, actually, I think it was only 80 that I was up highest on, and I was at mostly 45
Okay.
until I tapered down.
And how many carries did you ever make?
None.
Okay. And when you did you decide to come off it, or did it get cut off
Yeah.
suddenly for some reason?
No, no, I tapered down to like a half a milligram dose.
Okay. Okay, so you went off gradually.
Yeah.
And can I ask, just out of interest at the time, why weren't you able to get carries? What was the policy of that OAT clinic? How did they give you carries?
Well, had like lorazepam prescribed,
Mhm.
and I was also using other drugs sometimes, so I didn't have like a clean urine screen.
So they considered that you couldn't qualify for carries.
Yeah.
Okay. Um, and then you tapered off gradually, and I guess is that the time that you were seeing Dr. Wyman?
Yeah.
Okay. Um, and um, do you how do you currently think of yourself? Do you call yourself somebody in recovery? What how do you if we weren't talking in front of a whole bunch of people right now, and I just asked you, do you consider yourself an addict? Or, I mean, what would you say?
Um, I don't really identify as anything, but
Okay.
I do like I'm not absent from everything.
Okay.
Like,
I just realized that was maybe seemed like a little bit of a nosy question. I just want to tell you I am an addict in recovery. I call myself an addict. I go to a 12-step meeting, so we all go say, "Oh, I'm an addict," right? So it's something that I'm very
mhm,
used to using, like a throwaway term that isn't a big deal.
mhm,
Um, and I just wanted to tell you that because I know from firsthand experience that and I can hear in what you're telling me about that experience at the hospital when you gave birth to Malcolm, that other people might make you feel ashamed and guilty. And I think
mhm,
people with addiction ourselves often feel a lot of shame and guilt. So I just want to
mhm.
let you know that I get that. And I hope that I'm not making you feel uncomfortable or ashamed in any way.
Yeah, it's just something that I've never like really identified too much with, but
Right.
yeah.
Yeah, in my experience, I mean, there's as many ways to deal with addiction as there are people, and some people get over it and don't want to keep on talking about it, and some people think that it's a real central thing that always explains a lot of their behavior. So I wasn't sure where you stood. I guess I figured since you're willing to show up here today in public and talk this way, that you weren't too uncomfortable about it.
Yeah, I mean it
Right.
is what it is, right?
Yeah. So can you tell me a little, so tell me a little bit more about your story so you've mentioned people talking, I guess when they were getting you ready for the cesarean, oh, it's difficult to find a vein, there's drugs we can't give you, and then them paying attention to how you smelled and what you looked like and reporting you to CAS. What were some of the other ways in which you felt that your history of addiction was used against you?
They were not communicative in Malcolm's like care. I found like when I would come into the room, it would be like quieted down. They would use terms that were like, acronyms or something. They were not giving me a release plan for him. Um, like they
That was
would
the
just,
nurses.
yeah, yeah.
Okay. Did
They
and
didn't let me do the where you like sleep in the room with him. So I had this idea about when he would be able to come home, but I wasn't getting any answers from anybody. And I would ask, and they would be like, "Oh, we're finding out, or we'll update you." But like it just felt like it was almost like high school. Like as soon as you walk in, people are like,
Mhm.
like shushing down or looking at you. And there was other families in the nursery that I could see that the treatment was very different in how they approached them.
So not only did you feel like you were kind of watched and treated unfairly, you could see other people not being treated that way.
Yeah.
All right. And was any part of their like not telling you about the discharge planning, was that because they imagined that the children, because you mentioned the CAS worker being called, did they
Yeah.
imagine the CAS worker was probably not going to let you take Malcolm home with you?
Yes, that is true. Yeah.
Okay. But and what did in fact happen? So on the day that Malcolm was discharged from the hospital, what happened?
Um, I had met with the CAS worker. She didn't say anything to me about what was going to happen. She just met with me, and I didn't feel anything was wrong. So I assumed that, she had communicated with the hospital. And so they were kind of I was waiting to know what the discharge plan was. And so they had told me then that they were waiting to hear back from this worker. So the worker had given me her cell phone and number. So I called her in front of them on speakerphone and said like what's going to happen now, right? And I said they don't want to release him to me to take home. And she says like, well, why wouldn't he go home with you? So like that was kind of like, the answer that they were waiting for, I guess.
Mhm.
So I just was like, well, there you go. So
Hmm. And how involved did the CAS get? Did they come and do a home visit, like and check out where you were living?
we met at the hospital.
Okay. And so then you took him home, and what was home at that time? Where were you living and who were you living with?
I was by myself in an apartment.
Okay. Is it the same apartment you're still in now?
Yep.
Okay. And you said that was in Stratford.
Yep.
Okay. So listen, I think maybe we should stop here or pause and let people chime in. Is that okay with you?
Yeah, sure.
Can I just add before we stop, do you have anything specific you wanted to ask me?
Um, I just like want to feel like supported, I guess, in this journey if I were
Right.
to proceed in either way, whatever I decide. So, I just this was something that has a huge impact on if I'm gonna have a hard time or not. So, I
Right.
mean,
For sure. Listen, I look forward to being able to talk to you about that as things progress, and
mhm,
we'll talk a little bit about getting an ultrasound, so at least you know where you are exactly and what you so you can predict things a little bit.
yeah.
Um, and yeah, that's so my intention. I mean, things have changed a fair bit in the last few years. And I would, if I'm going to stay engaged, my job will be to help you feel well through the pregnancy. And that means not just feel physically well, the obstetric stuff, because
Mhm,
you have an obstetrics provider, and they're going to be looking after all the stuff to do with the actual
mhm.
pregnancy. But my job will be to make sure that you feel well psychologically, like that you're not
Okay.
feeling ashamed and guilty and pushed around.
Okay.
Is that okay?
Thank you. Yep. Thank you.
Okay, great. Thanks. So with that, Sarah, are you there?
I am.
So I'm not sure. I don't know that we actually explicitly talked about how we were going to field questions. Do you have, can you tell us?
Yeah, so we can, folks are welcome to put their questions in the Q&A box. Folks are welcome to raise their hand if they want to ask a question out loud. I can unmute you. There are no questions in the Q&A box yet, but I think everyone was probably quite riveted by that clinical encounter. So mhm. so
Well,
uh,
can maybe I'll just start things off. So
sure.
Charlotte, before you showed up, I was just talking about how doctors and researchers talk about the process of engaging with somebody, about how you form a relationship with somebody. And I was just pointing out that most of the papers, or a lot of the papers, ask how the doctor feels about the patient, but then they also ask how the patient feels about the doctor. Can I just ask you what were your impressions about how that went just now, us talking?
Like I felt okay. I mean, there's still hesitancy as I feel intimidated by most like healthcare providers. Just from the sense of fear that's been my experience. And because I had that infection that was kind of overlooked. I feel dismissed a lot when I do talk to people about what's going on. Um, when I had endocarditis, like I had gone to the hospital 3 times, 3 different hospitals in 1 week before
Oh,
falling into a coma. So
wow.
I was in a coma for 2 weeks and then was in the hospital for a long time. I feel like I just don't have the same, I don't get looked at the same as other people maybe. And so I get dismissed a lot and or like not believed. And that affects my healthcare.
Right.
So
Yeah, well, it sounds like you had some pretty scary close encounters.
yeah.
Yeah. And I guess no matter how well you and I get along right now, that doesn't take away the negative experiences that you've had in the past, right?
Yeah. Like I avoid healthcare altogether, even like, when needed. So
Right.
and that's like the residual effect.
Okay. Um, well, let me, if I may, I was really, first of all, I'm really relieved that you showed up because I thought I'm going to have to talk for a whole hour. But I thought this went really well. Like I was kind of doubtful about how well you and I were going to be able to kind of form any kind of relationship in this totally artificial session, right? Like
Mhm.
you're not really pregnant. I'm not really your doctor, and we know that there's a bunch of people watching us. But it did feel to me like I kind of forgot that at some point. Like it was just you and me talking to each other.
Mhm.
And
Yeah.
one of the things that I put up when in the slides was about, and particularly an article about doctors and nurses work and counselors working with pregnant women, how important it is to maintain eye contact. And it actually seemed to me, it does sort of feel like we were looking at each other, right?
Yeah. Yeah.
Am I right? Okay,
I
great.
had like some ease, I guess, just knowing like your history. So I mean that helped a bit. And like the work that you do, but uh it's still like an intimidating process like to
For sure.
encounter because everybody has different biases or judgments and you know.
Yeah. Well, listen, I really appreciate you doing this. Thank you.
Mhm. Thank
Thank
you.
you both. There are comments in the chat about how I guess authentic and as you say, it's an artificial situation, but I think you both really brought a lot to it, and I think it was illuminating for everyone. So thank you. There are a couple of questions in the chat, if that's okay. So the first question is do you have any suggestions for how to engage with nursing staff who may hold stigmatizing views towards patients who use drugs? What kind of education strategies or approaches have you found effective in reducing stigma and encouraging buy-in for harm reduction practices?
And sorry, is that directed to
I
Charlotte
believe
specifically?
I believe so. I believe that is directed at you, Adam, as a physician who perhaps has colleagues, nursing staff, who might not who might hold stigmatizing views.
Well, I'd be curious here because I know, Charlotte, you talk about this a lot. Like, I think when I met you at CSAM, you were doing a talk that day.
Hmm.
So you've probably engaged in this quite a bit. What would you say to that question?
I don't really have like an answer other than like allowing opportunities like my presentation at CSAM to exist, where that, it might be heard by people that, can kind of check their own practice. But yeah, I mean, I would like really enjoy or to see like something that's in hospital that's a learning opportunity. I do some work with the U of T medical program with Cash about patient experiences, um, stuff like that, like more opportunities to be sharing what it feels like so that, in front of people, like humanizing it.
Right.
Yeah.
So people hear the experience of a human being and what it felt like.
Yeah.
Yeah. Yeah, I mean, that's been my experience too. Like since actually I was curious that you mentioned 2013, I think, and 2013, 2014 when you were sick with endocarditis. That
Yeah.
was precisely the time where the hospital that I worked started introducing the idea of maybe we should have somebody who knows a little bit about addiction rather than, just treating it however. I mean, treating it as a separate thing that the person is dealing with. And
Yeah.
also when our hospital started allowing, and there you go, I'm kind of using this bossy language, but we started putting women and their babies together, even if they were on methadone, and even if the babies had some withdrawal from
Hmm.
methadone, rather than
Hmm.
putting them in the nursery. That would, like you were describing, because that was a lot of women's experience, feeling shamed and guilty and weird when they walked into the nursery, as though everybody was looking at them and judging them.
Hmm.
And so, yeah, so I mean, I think I'm pleased to say that what you just suggested we do is one of the things that we've been doing over the years, is having like talks. We do like in-services and presentations
Yeah.
about addiction.
Like, unfortunately, I did like write an email to like one of the head people of the department
Hmm.
during the time, and it was dismissed and shut down. And I was like, well, okay, now it's more easy to understand how this behavior like is happening when it's the leader that's like,
Right,
not somebody that's approachable or communicative about what my needs are. Like, no one
right.
asked me anything. They wrote things on my son's chart that were like not even the case and very dismissive and judgmental.
Huh.
Like, like his father's no longer in the picture. That's not the case.
Hmm.
Like, I used to donor. I had a child on my own because that's what I decided to do.
Right,
I planned that.
right,
And so, like, that just gives a connotation of, like, an unstable household or something,
right.
by putting in there father no longer in the picture. Like, no
Yeah,
one, like, that's not,
yeah.
like, it's just so mind-boggling that that's the treatment I received. And no one cared to ask me anything that was actually about me to check their judgments or answer these questions. They just assumed. It was like I was fitting a narrative that they wanted to make of me. So it was very difficult.
Well, I've seen that happen a lot, and I just want to say that I think, not to pat ourselves on the back, but I hope that's what you and I are doing here now, is like doing this demonstration and talking about it openly without a lot of
Mhm.
stigma and mystery, is just will be another example for people to see of a human being. You're a human being dealing with some complicated stuff, but that doesn't
Mhm.
make you any less human, right? I mean, I think that's for you and me both. That's why I often make a point of disclosing the fact that I have a history of addiction myself.
Mhm.
Yeah, absolutely. Another question that's come in, would it have been appropriate to ask about whether the patient was using any drugs at the time of this encounter? Would it have been an opportunity to discuss the need for OAT?
Um, yeah, well, of course, one of the things that was artificial about this, Charlotte, is that I was a whole lot more relaxed about not interrogating you, because usually I know I have a limited amount of time, and I'm expected to come out with a whole bunch of information.
Mhm.
How would it have felt to you? How could I have brought up that? Like, I didn't ask you any details about how did you get pregnant this time, were you planned, blah 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 blah, which is all stuff I would eventually get around to asking. But I mean,
Mhm.
usually in human interactions, we get people warmed up a little bit before we start throwing a whole lot of private, intimate questions at them. How can you imagine
Yeah.
how it would have come across if I had asked you right away about, or how I might have introduced that question?
Honestly, I think the best approach for me, which is probably not for everybody, would have been just you requesting a urine screen and finding out yourself. Like, because I feel like ask me directly, I wouldn't want to talk about it.
Ah, and you that would have been something you would have been okay with if I said, "Hey, before we're finished, I'd like it if you would give me a urine screen, a urine sample for a tox screen. Is that okay?"
Yeah, I mean, like if you ask me about it and I just like, I mean, if I say no, then that's a little bit, concerning. But
Right,
that's the approach that I think would have worked best for me. But I can't say that that would have been for everybody because, like if you ask me, like if I smoke cigarettes, I could say maybe yes. But if you ask me, like, if I was anything else, I
right.
might not feel comfortable about. But like, um, so like that would be a way that I could ensure that I am getting care that is appropriate for my needs without actually having to like discuss it too much.
Okay.
But I don't know. Like I know there's a lot of like, opinions about urine drug screening, and I mean, I did not appreciate it during methadone, but
Right.
in this case, it would
Right.
be like, there's yeah.
And just to be clear, just to set the record straight for everybody watching, you're not pregnant, right?
No, I'm not
Okay.
pregnant.
Okay. So just so everybody can relax. All right. Thank you.
Yeah, I think it's an interesting. You make a great point, Charlotte, that people are different, right? And that's probably one of the difficulties in this type of encounter. Adam is like, how do you know what? And you're kind of trying to gauge, and you have your experience to draw on, and your own intuitions and perhaps impressions of a person, but you don't. Not everything is going to work for everybody. So it's kind of a difficult situation where the development, having the time and space to develop the rapport is really important. And it's difficult in this type of, well, in particular, this type of situation where we have limited time, but in any clinical encounter.
Mhm.
Yeah.
Another question, Adam, would you engage with other clinical staff in advance of a planned admission for delivery to help navigate, talk about meds, document lack of need to call CAF?
Yeah, that's a good question. And we have had most of our success. We had most of our success before COVID, uh, during which time the demographics of patients that we were seeing at KGH dramatically changed, and I'm still not entirely sure how to explain that. But the ideal for us was a woman would get referred to the obstetrician or the family doctor or the midwife, like as close to the early part of pregnancy as possible. So before 20 weeks was great, because then you had a chance to engage and talk about things. And we sort of had a loosely based team where I was the physician. There was a nurse practitioner who had worked in the NICU and who knew a lot about the effects of opioids and what withdrawal looked like in babies, and was also very kind and very supportive and excellent and competent. And then we had a social worker who also was specifically assigned to working with mothers and families who were struggling with social issues like addiction, homelessness. Uh, so over the course of time, we would get to know people, and our hope was that as we got close to the delivery date, things usually would get better. So I mean, if a woman came in and was still using illicit opioids and was in danger of overdose and chose to go on OAT, and then also got engaged in applying for benefits and getting more secure housing, by the time it came time for her due date, there was often explicitly a whole lot less reason to worry about it and for her and about her. And but there was also a community-based program called Thrive in Kingston, which we had no control over. It was run by the community health center, and it worked with a couple of women who would go and essentially really form friendships, professional friendships with the women who were parenting kids or were pregnant while they were also engaged in substance use. And they would always, their thing was, listen, it would be to your benefit if you and I call Children's Aid so somebody else doesn't. Because in your situation, where somebody called the CAS on you after Malcolm was born and was in the NICU, if somebody, I mean, probably Thrive would have said, you know what, this is probably going to happen. Why don't we call Children's Aid and just let them know? What would have happened then is somebody would call Children's Aid and they say, yeah, we know about Charlotte. She's already talked to us, and we thanks very much. We've got this. Like, she's already on top of
Yeah.
this, right?
The funny thing is that the CAS worker had said that they had asked the person who had made the report if I appeared like I was under the influence, and they said no, because I wasn't. I didn't smoke weed. I was just like getting a ride from somebody who,
Right.
selling it.
Right.
So like it, I didn't appear to be like acting in that manner, but
Well, they probably made a lot of assumptions about you,
yeah, exactly. Yeah.
right?
So we're just about at time. There is a question in the chat, sorry, in the Q&A that I would love for folks to maybe go perinatal addictions care chat room in the lobby to talk about. It's about, was curious if anyone had used Sublocade injection with pregnancy, or if anyone has had a patient become pregnant while being on this form of OIT, which I think is a great question that we don't really have time to get into right now. But I do want to encourage folks to maybe go and pop into that chat room and talk about it, because I think that is something that will probably come up more and more as the depot becomes more hopefully more available and more used.
That would be a great topic for next year.
Yeah, great point. Great point. Thank you very much. I want to thank both of you, Adam and Charlotte, for this really fascinating clinical encounter that you had, for the discussion. Thanks so much to all the attendees for your engagement. Lots of appreciation in the chat for how valuable a learning experience that was. So everyone, we're now on break. I'm sorry I've eaten into your break a little bit, but we're on break until 9:45 when the next round of sessions start. So I hope that we will see you all then. I put a link to the feedback survey in the chat. Please do fill it out when you have time. They'll be sent out also at the end of the day to your email address, so don't worry about it if you couldn't get to it right away. So once again, thank you, Adam. Thank you, Charlotte. Thank you, everybody. And we will see you soon.
And can I just, before we so Charlotte, I'm going to send you a link by email so you and I can connect after this, okay?
Okay, thanks.
Great. Thanks. Thanks, everybody.
Thank
Thanks
you
very
very
much,
much.
Sarah.
Thank you.